So, hi everyone. My name is Lottie, and I work for the Pituitary Foundation. So, for those of you who are not using visuals, I am a mid-20s woman with dark hair, with blonde streaks, and I'm wearing glasses. So, we're very Professor Stephanie Baldeweg today, who'll be answering all your questions. So, Stephanie, would you like to introduce yourself?
So thank you very much, Lottie, for the introduction and explaining the house rules. I'm an endocrinologist at university. I'm a professor at the attached university in endocrinology. I'm head of the department, so looking after quite a lot of staff and loads of patients. I initially trained in Berlin, and then all my postgraduate training since 1991 has been in and around London. I'm currently chair of the clinic committee of the Society for Endocrinology. So that is a society, country, trainees, consultants, nurses, so anyone with an scientist, anyone with an interest in endocrinology. I'm also a trustee on the board of the Pituitary Foundation and the vice chair of their medical committee many years. I have a special interest in pituitary disease. I look after all endocrine disorders and diabetes, but I have a special interest in pituitary disease. And a lot of my research looks at patient outcomes of certain conditions. See that there is much more research and information done on patient-centered management. So the patient in the center of the management and patient-reported outcomes, so the patient experience. I'm also machine learning. So can we use the cleverness of a computer and of networks to streamline things and make them more efficient, where you don't need a human, which then would allow us to use for the things where it is helpful to have a person to interact with the patient or the person. So I think that's it. What else to say? I'm married, I have 2 children, I have 2 grandchildren, so I'm spending a lot of time in the forest, really. Main pleasure. So we've done a lot of these Q&As in the past in person, which have been great. So I may or may not know some of you. I don't know everyone by name. Line, I hope it works equally well. And we just see how we get on. So I'm looking forward to your questions. I've got 2 questions to start off with, if we are happy with that, Lottie.
Yeah. Some of our members have submitted questions beforehand. So yeah, if we get going with those, and then we'll open the floor to questions from the audience.
Lovely. So I'm starting with the first question from Fiona. Are you on this call, Fiona? Yes, you are. So you know who you are. And your question is, you were saying you had panhypopituitarism since the age of 12, and you're now in your early, if it is possible that you're experiencing inflammation, tender areas all over the body. You're also asking, are there any other long-term side effects of panhypopituitarism since childhood? Hypopituitarism causes excess abdominal fat over such a long time, despite healthy eating and exercise, and what can you do about it? So 3 questions really. Is inflammation related to panhypopituitarism? What are the long-term effects of hypopituitarism, and what about abdominal fat? So let's start with I'm going to start with the long-term effects. So panhypopituitarism is just another word for an underact, and that would be, the pan means it's all the hormones. Usually it means the anterior hormones. So this is hormones controlling fertility and testosterone and estrogen, hormones controlling cortisol production, hormones controlling prolactin and growth hormone. There's also sometimes panhypopituitarism includes the posterior gland, and that is the hormone controlling vasopressin, as well as some hormone called oxytocin, which is very trendy but not at the moment replaced. So the long-term effects, once you are well replaced, so once all your hormones are optimally replaced, saying mainly cardiovascular and metabolic problems, which goes into your last question, this excess abdominal fat. We don't quite know why patients who have panhypopituitarism have a high of heart attacks, of strokes, of diabetes than others, but this is certainly the case. And there's a lot of ideas of whether it is that people are having perhaps too much hydrocortisone, or whether we are not replacing. But it is especially important to focus on other cardiovascular risk factors, so blood pressure, blood glucose, cholesterol, and exercise. And more we know that really is probably the main thing. So there's recent guidance for patients with diabetes, which is a different group but has a similar high risk, about the 5S, and that is sweating. So you should sweat, stepping, you should walk every day, Sleeping, you should try to sleep 6 to 8 hours. What else is there? Sitting, so you should avoid sitting for prolonged hours. And the last, and possibly not to smoke, but it's all about being active, which would help. There's no specific treatment for the abdominal sort of increased abdominal fat. Unfortunately, look whether you are on too much hydrocortisone, whether that is optimal, perhaps to look whether you could have more thyroxine. Sometimes there's room to increase the thyroxine. If you're on growth hormone, whether that might help you. And then, of course, as we get into our 40s in women, of course, there's also changes, sort of perimenopausal changes. So sometimes overall metabolic changes lead to more abdominal. And then your first question, Fiona, was on inflammation and tender areas. And I'm not aware that this is related, actually. Yeah, there's increased inflammation or tenderness after many years of hypopituitarism. So I would suggest to look for other causes, again, to look whether you are optimally replaced. Fiona, perhaps could you just sort of say in the chat whether that answers your question, if you don't mind? Right. Lovely. Thank you. So that's, I think, we are. There's a question which I'm going to take, and then I'm coming back to a question which was asked in advance. But there's a question from Nolene. I hope I pronounced your name correctly. We don't really know. We just know that for example, under replacement of thyroid hormone will give you a higher cholesterol. We know that the fatigue associated with pituitary disease often means they might otherwise, and we just know that that's a higher risk of cardiovascular disease. So we think we would want to focus on the cholesterol more than we might if you didn't have pituitary disease. Your question in a moment, and Fiona says thank you, so that's good. So let's go. The second person who submitted a question was Joe, and I'm just going to see, Joe, whether I can see you on this chat. And if you assume you are JB, so let's just assume that, and off we go. So this is quite an extensive question. I'm going to take it apart and see how we can go. Under the present NHS, what would your advice be to a patient who suspects they may have cyclical Cushing's but have insufficient test evidence to meet the referral criteria and does not wish to further humiliate themselves or waste? And I think the next question goes with it. Would a privately funded 3T, so that's a 3 Tesla, so that's a certain type of scan, is a good scan, MRI scan of the pituitary gland be helpful? And if so, would a pituitary expert a diagnostic check of that scan? So I'm going to start with that, and then I come back, Joe, to the rest of your questions. So cyclical Cushing's, for those of you who don't know, is a condition so Cushing's disease is a condition, a surgeon called Harvey Cushing's, who discovered that a tumor of the pituitary gland can lead to overproduction of ACTH, so a hormone that then stimulates the adrenal gland to produce so this is Cushing's disease. And then there is a condition which is very, very rare, and some people say it may not exist, some people say it does exist, but it's impossible to diagnose, which is instead of having excessive ACTH all the time, people might just produce this ACTH at an interval at random every 3 months, every 3 years, every 3 days. And it is so. I appreciate, Joe, you're being prudent, I would say, with the NHS resources, and you don't want to put. If you think you have a condition which has not been offered enough testing, I would ask your GP to refer you to an endocrinologist. I think it's such a rare condition. It's very difficult to diagnose. We sometimes suspect it, but don't diagnose it. Sometimes we think it's probably not it, but maybe something else. So I would suggest you should be referred to an endocrinologist with a special interest. You should ask your GP to refer you, and I would not worry so much. I think limited resources is a whole topic for another day, and that's on the back of years of underfunding. But for you personally, I have to refer you. I don't think you should have a scan of the pituitary gland in advance. Because I don't think that would be helpful, because about 1 in 10 people have an abnormal pituitary gland on a scan. It leads to a lot of anxiety. It may lead to unnecessary and cause harm, and it may not actually further your diagnosis at all. It may just be a red herring. If you did have a pituitary MRI in the private sector, of course, any endocrinologist in the NHS will be able to review with my radiologist, review scans done elsewhere in the UK or abroad, and that is common practice. So yes, everybody would be able to review the scan. The next question is that we narrow angle glaucoma and Cushing's disease. And you said you were concerned by this due to decline in your eyesight, sore eyes, double vision, and ask for a referral to Moorfields Eye Hospital, where you receive bilateral surgery, which has helped you and stopped you from going blind. Should other people be aware of this? Is there a genetic link to endocrine issues? And I know that there is some conditions which are related to Cushing's disease, and that's the extent of my knowledge. So I can't comment more. Again, I would think if you thought you had an eye condition, you need to see a specialist, which you've done. We are sometimes get patient of Cushing's, but again, it's very rare, and I'm not an expert in eye disease, in Cushing's disease, so I can't say more than that. I hope, Joe, that is helpful to you.
Yeah, I think Joe has said thank you in the chat.
Perfect. So I'm just going to go. I know, Lotte, you were going to read them, but I'm a visual person, so I may actually just read them myself.
That's okay.
I need to see them. So I think Noeline, we done. Gemma is the next one. Yeah, and Lotte, if I miss something,
yeah, of course, I'll let you know.
So the next question is from Gemma at 11:12. It is, you've been diagnosed with a microprolactinoma and have started cobergolin. 3 months after starting cobergolin, you've experienced a lot of hair loss. Is this normal, and is this body adjusting? So cobergolin, for those, so a microprolactinoma is a tumor, a pituitary adenoma, which produces prolactin, and it's the only pituitary tumor which can be treated with medicine alone, where surgery isn't the first to be treated surgically, but we now have a group of drugs. Cobergolin is one of them, which works on receptors, so shrinking this pituitary adenoma, lowering the prolactin, excuse me. When you have a high prolactin, often it interferes with your sex hormones. So for women, your periods disappear, and you have low estrogen. For men, this could affect fertility. When you start using cobergolin, your prolactin will come down, and your either testosterone or estrogen, your man or woman, will normalize, and that can lead to a loss of hair. A bit like pregnancy, when you have very little. A big change of hormones, and then once you've given birth, things normalize, and then women can lose quite a lot of hair. Yeah, it's not something women report, so it's not something people come to me and say all the time they have it, but I would think that 100% can be explained by hormonal shift. Perhaps get an iron test, because another cause of hair loss in women, especially, I don't know how old you are, but women who still have their periods, can be iron. Excessive blood loss, so I would just have an iron check, and then you could have iron over the counter, and that might help a lot. So that's Gemma. I hope, Gemma, I hope you are happy with that. And we're going to Pamela Smith. Pamela is asking, is there an alternative to levothyroxine? I have lots of problems with taking different brands. So this is a really good me here, Pamela. There is something called liothyronine, which is T3. So levothyroxine is called T4 because it's a thyroid hormone with 4 iodine molecules. It's shaved off through an enzyme, and then you make T3, which just has 3 iodine molecules. And we all make T3 from T4. There is T3 is available to be prescribed on the NHS, partially for price, partially because there's very little evidence that it is better. I am, as we speak, involved in writing on who should be offered T3 as a trial if levothyroxine, which is T4, is not working or causing trouble. So it's at the moment regulated by each local group who's allowed to have it and who isn't. For example, at UCLH, we are not able to prescribe it at the moment. And we are writing a guideline to make it fairer for everyone and explain in which situation it should be tried. Yeah, but I think some people have actually not the problem with the levothyroxine as such, but with the carrier, so the substrate in which it is made. So it may be that if you find a brand which works for you, that's the brand to stick with. It's rare, but it's possible. So that's Pamela. I hope that answers your question, Pamela.
We've just had Gemma's just replied about your previous question about hair loss, saying that she is 39 and didn't offer her one.
Didn't offer her one. Yeah.
She says her GP refused.
Yeah. Yeah, it's tricky. I can only say. I think if you had very heavy periods, it may be worthwhile to take some iron at the time of the period. But I don't know your medical condition, so I can't really advise more than that. Yeah. The hormonal shift for now, for Gemma.
I think
so. Let's go.
We're on Rena next, I think.
No, that's helpful. So we're going to Rena, yeah?
Yeah.
Rena, hello. removed, which was causing Cushing. So this is a condition which makes too much cortisol. We just talked about this, Cushing's disease. You're now experiencing really bad muscle and joint pain. What is this being caused by? Is it withdrawal of cortisol? Is the effect of... So this is a really good description of what happens. And we don't know the answer, is the truth, but it's common. So people who run very high cortisol levels, when you therapy or medically, their levels drop, and you may need to replace them with hydrocortisone, which many of you will be familiar, and they feel terrible. And as people feel terrible in the year after the surgery, I'm really pleased because it shows that the surgery has worked. We don't feel pleased that you have terrible, but we feel pleased that the surgery has worked. And I suspect it's a change in the so it's on the background of having high cortisol levels, and I think then changing the levels, they're very sensitive to this change. We know that in most people, with exercise and time and careful replacement of all the other hormones, this disappears. Years who had Cushing's, who was very, very troubled by pain in her muscles, and after 2 years, she was able to go back. She played tennis before. She loved playing tennis. She stopped when she developed Cushing's disease. Years to build her strength up and get rid of the pains. So it's so I don't think we 100% know the cause, but it's very well described, and it's really very, very difficult. So I feel for you, but I would hope, I don't know how long you say I've just... So I would hope that over the course of a year, with gentle exercises, walking, swimming, Pilates, whatever you enjoy, that this should improve a lot. So I hope that answers Rena's question. I'm going to Chris. Hi, Chris. The question. Hi, Chris is hypopituitary for 15 months after pituitary gonadotrophic adenoma apoplexia. After taking levothyroxine, the blood level was 18 and then was dropped due to increased growth hormone dosage. Is there an optimal blood level for T4? Thanks, because it will affect many of you, and it's one of my pet questions. So Chris is telling us that he had a pituitary adenoma. We don't know whether he had surgery or not, but he had an apoplexy, so there's a bleed. They had a bleed into the tumor, which is an apoplexy, leading to an underactive pituitary gland. Sometimes then people need surgery, sometimes they don't. And one of the effects we talked about is the loss of the TSH, which is thyroid stimulating hormone, which leads to a low free T4. So that's the levothyroxine, the free T4 we just talked about, which is a circulating thyroid hormone. 22 or between 12 and 22, it depends which chemical agent is used. And in patients who do not have pituitary disease, so if the TSH is used to adjust the thyroid levels. So you look at the TSH and you want it to be in the normal range, and the GP will adjust generally the dose of the thyroxine. If you have pituitary disease, the TSH is active, and it is wrong to use the TSH to adjust your thyroid level. So often people have a normal T4 level but have a low TSH, and the GP will say, and not very used to pituitary disease, they will say cut down your dose, which for most people, for everyone with a thyroid disease, would be appropriate, but not for those with pituitary disease. And so if you're on thyroxine, your GP says we need to reduce the dose, I would say I would like to discuss this with my endocrinologist. Very, very common, because it's so rare, and it's sort of, they know it, but they're busy. They always have their focus on. So I would say you should have your T4 dose only adjusted, free levothyroxine dose only adjusted by a GP. I tend to have it in the upper third of the reference range. 14, I would think maybe a bit low. 12 is definitely low. So I would, for all the reasons mentioned earlier, for cardiovascular health, for metabolic health, for well-being, I would aim for a free T4. Yeah, so 18 would be perfect for me. And if it drops due to increasing other medications, then it's a free T4 should be adjusted. This levothyroxine dose should be adjusted. That by the Pituitary Foundation on this as well, to show the GP. Also, this is Gemma who's telling us, yeah, Gemma, I hope it works out, but it should settle. And you're already taking the iron, perfect. So the next question is from Claire. Hello. Claire says she needs to have her gallbladder removed shortly within the next 2 months. Is there any precaution she needs to take for prolactin anesthetic affected? So this depends on your pituitary state. Claire, if you have an underactive pituitary, this needs to be increased. So you need to follow the 6-day rules, which are on the Pituitary Foundation website. You should have this from your endocrinologist. And that is really life operation if you are on hydrocortisone, if your hydrocortisone dose is not increased. And so there's on the Pituitary Foundation website, there is information. On the site for endocrinology website is information. There's a leaflet and that is important. They should be worn by your team. I would also let your endocrinologist know, because then they can write. If you are not on hydrocortisone at the moment, I think it would be prudent to assess cortisol production is appropriate. So your ACTH cortisol. So again, I would ask this question absolutely and to your endocrinologist to say you're about to have surgery. Would you need hydrocortisone? So either they will have assessed you and said you're safe without it, or they will not have assessed you, in which case they need to do it. Sometimes there's a long wait to assess people, and then it's the safest to use hydrocortisone around the time of surgery. They're not using it if we are unsure. So if you know you need hydrocortisone, you need to increase the dose, follow the safety rules. If you know you don't need hydrocortisone, then this shouldn't affect you at all. And if you're unsure, either you need to be, or you need as a precaution have hydrocortisone to keep you safe.
Yeah, and just following that, we do have another talk about preparing for surgery. On our website, and we also had, I can't remember who wrote it, but it was an anaesthetist who wrote all about going into surgery. So I'll try and find that blog now.
That's brilliant. Yeah, and that's probably the most of all the questions. There may be other really interesting ones. That's the most important question that might save lives, that question. So thank you for asking that. So Rina says thank you, and we're going to, all right, so you're just suggesting to Parathon to put this question in a chat. Noeline says thank you for asking our previous questions. Another question, is there any B12 deficiency? Not that I know of. I think if you thought of pituitary disease as an autoimmune disease, which some people do, then you could say B12 deficiency is another autoimmune disease. But I'm not aware of an actual connection. And then Fiona is asking, oxytocin seems to be a key hormone in everyday life. How significant is that we can't produce it in panhypopituitarism? So oxytocin is an absolutely fascinating hormone. It's produced by the posterior pituitary gland, so the back part of the gland, and it is produced actions mainly. So someone hugging you, someone being kind to you. They've done studies on a little mammal like a rat. Is raising the pups. So interesting enough, the mother gives gives birth, and then the father, so the male of that rat, is looking after the pups. Oxytocin away from them. So when you block the oxytocin, this male rat just walks away from the pups. They lie there, they cry, they want them, and he just doesn't care. And then when you replace oxytocin, he goes back and takes his studies on patients who had brain injury and who are sort of having self-neglect, having low oxytocin. There's some studies on young offenders having low oxytocin, and it doesn't mean low oxytocin makes you offended. Life so far and have low oxytocin levels, and there's some studies to try and replace it. So at the moment we are not replacing it. We don't know how significant it is that we are not having it in panhypopituitary hormone. In my time of practicing as an endocrinologist, we will probably start replacing it. Yeah, I think it's a really interesting hormone. We know it gets produced by love and by loving interaction. So we don't really know what it does to you when you don't make it. But most people don't have posterior pituitary deficiency. Most people have anterior, so the front. So it's a smaller group of people who it may affect. Connor says hello. Hi, Connor. So Connor has been recently diagnosed with Cushing's disease. So again, overproduction of cortisol, and is in the process of exploring the cause. So Connor's having had a pituitary MRI and is waiting for the results. Received fantastic support. So Bart's Hospital is one of the great London centers. We are working closely with them. In fact, we're doing our surgeries at UCL. There's surgeries at UCLH. We're having with the endocrinologist at Bart's leading the pituitary work. So it's a great place, and we are sharing our expertise. You're very early in your days of your journey, so you're on a journey. So I think that's the only model of care we can think of, as opposed to come, be treated, and get better. It is going to be a long journey. You're on block. It's giving you hydrocortisone and metyrapone, so a drug to lower your cortisol, but one to keep you safe. With hydrocortisone, keep you safe. This has positively impacted on your symptoms, weight, stretch marks. My question: can block and replace? Yes. So you're on metyrapone, be a long-term treatment plan. So Cushing's disease. Cushing's. I assume Connor has Cushing's. So something called Cushing's syndrome. So this is people who produce cortisol without it being under pituitary control, or people who are being given high dose steroids for other conditions. But so assuming you have Cushing's disease, so really you're saying this is an alternative to surgery. I don't think we generally do this. I have a small number of patients where I use block and replace, so this metyrapone plus hydrocortisone. So levels, and these are people who cannot have surgery for whatever reason. So they have other medical conditions. One is very frail, for example, and it would not be safe for them to undergo surgery. Surgery would be much more sensible, because I think you don't have the side effect of the metyrapone. I think you can much use your hydrocortisone. To block and replace is quite a blunt tool. It's very helpful in your situation, but my personal feeling would be, unless you have a good reason why you couldn't have surgery, or your tumor isn't amenable for surgery, or I would think, and I think that's all endocrinologists would think, that surgery would be your first treatment option. Sometimes people who can't be cured with surgery, but I think surgery probably would be offered to you first.
And yeah, Connor's just added in the chat at the bottom that he was initially diagnosed as cyclical Cushing, but now have constantly raised AC.
Yeah, so but I mean, Bart is a brilliant place. We probably, Connor, will discuss your case in our pituitary meeting, which we discuss everyone once a week. So you may working life. But Bart is an excellent center. And if you need surgery, you will have this at UCLH, so at the National Hospital for Neurology and Neurosurgery. We have 3 surgeons who are very experienced pituitary surgeons. And then we look after you post. So it's a very good setup. Mina Hashimi. So hello. Miss Hashimi says therapy, and she's currently on medical therapy. So again, metyrapone, same drug Connor was talking about, but struggles with stomaching the capsules. It gives me burning and sensation in my stomach, and she gets dizzy. What would be the next step for me? As isn't another Mina Hashimi, you are actually under the care of UCLH. So I would suggest this in anyone, but in you particular, to discuss it with a different Mina Hashimi, then discuss it with your endocrinologist rather than on this chat. I think that's too specific a question, really. Yeah, so the treatment for Cushing's is surgery, which sometimes we take the adrenal gland out. That's another option. So there is no one to produce cortisol, and medical therapy. So surgery, pituitary surgery, pituitary radiotherapy, medical therapy. Options. If it's just the stomach aches, then I would think obviously something to protect the stomach. And if you get dizzy, obviously to make sure your cortisol levels don't go too low. But so I should discuss this when you come to clinic with me or my team. If you have another endocrinologist, you should discuss it with them. Parathan, hello. I think we met before. Remember correctly, hello. Are there any psychological support services at UCLH specifically for pituitary patients? Unfortunately, they are not. I think there should be. We have psychologists. We don't have half a psychologist. We have a psychologist half-time in the diabetes service. And we have some psychology support for late effects. So these are cancer survivors, survivors of childhood cancer. Of late effects of this. We have psychology access for those. We don't at the moment have, unfortunately, psychological support for pituitary patients. I would love that. I think funding at the moment, or has been, for something we at the moment are able to offer. But as I say, I think that would be amazing and well needed.
Yeah, we agree. I think that would be amazing if hospitals were able to offer that. We do try and have Jackson, who is a psychologist, and she does a lot of talks for us, and she's also written a lot of blogs, and we know that's not perfect, but it's sort of better than nothing. So I'll try and find some links to some. We did do a talk as part of the Awareness Month events as well, and so hopefully those things might be able to help you as well.
Lovely. No, that's really helpful, to signposting. Thank you. So tumor large, so macroadenoma means it's bigger than 1 centimeter, removed January 2021, and now has adrenal insufficiency and hypothyroidism. So low ACTH, low. How often are we supposed to have a short Nacken test done? And should I have an emergency hydrocortisone injection in case of adrenal crisis? So 2 questions. So the second question first, and Lottie will put a link in for sick day rules, and you absolutely should have an emergency hydrocortisone injection in case of adrenal crisis, and that should be provided either by your. So we often write to the GP and ask them to provide it very clearly. Our nurses would teach you, so I'm sure this is available in your endocrine unit as well. Information on the Pituitary Foundation website on I think that's a video by John Watts, is that right? I can't remember.
Yeah, we have a video on giving emergency hydrocortisone. I think it's from the Liverpool hospital.
Okay.
So yeah, but I can share those links now. We do have a whole section on our website about adrenal crisis and everything like that.
Exactly. So you have all the information and all the tools to manage the first part of an adrenal crisis before you get help. And I think that's especially important now that we worry about delays in ambulance time, arrival. So you should hydrocortisone injection. There should be somebody who you know who either lives with you or is close who might help you with this if you were unwell. And that would be very, very important. The test. So different centers do different things. I don't use the Schwarzenegger test in generally in people with pituitary disease because I am using something called an institute. So this is a test which directly tests the pituitary gland as opposed to the adrenal gland. Yeah, and a lot of debate. There's whole sessions on conferences, which is better, which is more suitable. my reading of literature is that it is a finer instrument to use a glucose stress test or an insulin tolerance test. It also allows you to look at growth hormone dynamics at the same time. After you had surgery, so 6 to 12 weeks after surgery, we would assess whether your ACTH cortisol axis is normal, and then I would not reassess. You may lose function over time, then we would reassess, or something in your clinical story or your well-being tells us that we are wondering whether things have changed. Yeah, and then the first step, 9 a.m. in the morning, and then that would help us to decide whether I need further tests. So I would not routinely do an assessment of the pituitary adrenal axis after once. Assume there's no real change, but would just do obviously annual checkups for that. So Lottie's put, the next thing is 11:31. You can see Lottie put an article in the link for pituitary patients. It's really helpful. Oh, Nolene just thanks me. Thank you. And Lottie is putting a booklet on pituitary surgery. So these are really great resources. And then Lucy. Hi, Lucy. Lucy's TSH. Lucy's on. So Lucy had surgery for pituitary adenoma, and she sends me her numbers, and she said, I'm on too much, and I have to say here, I cannot advise on individual case. For my reasons would be unethical. I would not be insured. I don't know your whole story. Having said that, looking at these results, the T4 to me looks in a normal range. And if this was really thyroid, so pituitary-driven hypothyroid disease, then I would think that is a good result. But as I say, I don't know all your other numbers and your situation, so I would discuss it. Now you sort of have a bit. Connor, oh, this is Connor saying he's on the road to, looks like things have sort of focused on Cushing's. Nina is saying, yes, she's with us. So this is for Mr. Shimi. Mina, I would just, I don't know when your next appointment is, but I would just saying, if you're not well on the, let us know, and we'll see you and see what should happen next. Yeah, I think one of my very senior fellows' rules is looking after you closely, so we can help with that. And now I
think we're at Leon.
Yeah, so I've got Gemma saying thank you. Well, that's lovely, thank you. About the psychology. And we've got Leon, lovely. Leon is saying, hi Leon. I'm similar to Connor. I'm on block and replace. I've been recommended a bilateral adrenalectomy. I assume that's the abbreviation. Metyrapone doesn't seem. I've been offered psychological support is much needed for Cushing's disease. And the bilateral adrenalectomy, if that's what the abbreviation means, is scary, Leon says. So Leon has a test called IPSS, which is inferior. So this is looking at ACTH levels in the pituitary gland. So stimulating it and then looking at peripheral and central to see whether the ACTH does indeed come from the pituitary gland. So this is in patients when we are not sure. There is a condition called ectopic Cushing, often a small growth in the lung, can be somewhere else, which produces the ACTH rather than in the pituitary gland. So pituitary surgery would not be the right treatment for this. And sometimes we can't find. Will have lots of scans of your chest, of your pelvis, everywhere else, and people will have looked like for a needle in a haystack without finding it. And then the treatment is exactly as we just discussed, is either medical or glands, because then if you have a lot of ACTH and the adrenal glands are gone, they can't produce cortisol, and then you would remain on hydrocortisone. So it is, I can see why this is a scary option, and So I'm glad you've got psychological support. Again, as I said, we don't have that, and that is very useful. So I think, and I'm just looking, I think you're just sharing, not just you're sharing your story, which is a difficult journey you're on. So I hope you have all the support you need. So Kim has shared a link on the psychological impact of pituitary conditions. So thank you for that. And the video about stress and well-being with pituitary adrenal crisis. So this is really helpful. And again,
yeah, that link on the adrenal crisis has got, we've got a new table out which shows some of the signs of the adrenal crisis, which I think people have found really step-wise to administering emergency hydrocortisone, and there's loads and loads of information on there as well.
Thank you. So that's really helpful. So we are going. Mina, you're obviously clever in doing that. Not sure how to find them here. And then it just says iPad to everyone. So that's somebody who's, we haven't got the name. So hello, I have also dilated cardiomyopathy. Have you any experience of this? So I don't. I mean, there's some pituitary conditions, which are upsetting the heart, like Cushing's disease or acromegaly, for example. So there's some pituitary conditions in where we will carefully monitor the heart. So people have ultrasound cardiologist, and it is possible that you're in one of those two groups. I don't know that. I don't. If you're not, then I can't see how pituitary-driven adrenal failure and dilated cardiomyopathy would go together. Yeah. So this type, maybe, if I don't. Yeah. I'm in 1 second. I think I jumped over Pamela. I'm sorry about that, Pamela. I'm going to come back to your. So let's go. So I'm going to go one up again. I think for some reason I jumped over Pamela. Pamela, so you're saying thank you. You're welcome. February this year and a heart attack, but have not been offered any further tests on hydrocortisone injection. So 100% follow that up. Yeah, 100%. I mean, in all the information from Pituitary Foundation, it will also say that you should be offered injection. Your GP might provide it, but I would also talk to the endocrinologist. Yeah, it is some centers. We also in UCLH we for a long time didn't do it because we actually thought if you live in London, it's fast and you're better off in hospital. You don't get false reassurance. But times have definitely changed, and so it will be possibly life-saving to have a hydrocortisone emergency injection before you go to hospital. You will once you used it. So I'm not going to see.
I think we've just got a comment from Sue at the bottom. More questions that they want to add in.
So Sue is saying, thank you for emphasizing cardiovascular weakness being an issue for hyperpituitary patients like myself. I'm in my mid-50s after being on treatment since my early 30s. I'm walking more and do some more exercise. So that's last sentence. That's for all of us. So we all need to get out more. And I think this excellent opportunity of doing detriment to our health, because if we had met today, we would have walked from the station to a place. We would walk upstairs to find the room. We would walk between places. We would have moved much more. So it's convenient. Join who might not have been able to join, but it is quite a poison chalice. I think it's quite yeah. It's not all wonderful. So yes, go out today in London. Autumn day, very blue sky, sunshine, very nice colors. So if you can after the session, go and walk. And we have Judith again, I think. I was diagnosed. So this is follow-up. Thank you, Judith. Cushing's returned, radiotherapy, both adrenals removed, last year diagnosed with dilated cardiomyopathy. So Judith has been through everything we've just said, surgery, and then bilateral adrenalectomy, so both adrenal glands removed. So that's a lot of medical intervention to manage to lower the cortisol levels. And consequently, from reading this, you will have had a lot of until it was managed to lower. We see, and you are now diagnosed with dilated cardiomyopathy. I mean, we see in people who we get new with Cushing's disease, poor heart function, and that improves a lot as the cortisol levels disappear. So I would have hope, I don't know in your case, but I would have hope it might improve. The surgery, so since you had your cortisol levels sort of more normalized, hopefully the heart muscle will improve. Exercise is probably the thing to do. I don't know how much exercise you can do, but as all of our muscles, you can also retrain to an extent your heart muscle. Yeah. But the only other thing to say, other cardiovascular effects, so blood pressure, cholesterol, glucose, weight, being sedentary, all must be quite aggressively addressed, more than you might do in someone of medical story.
Yes. Yeah. Okay. Thank you.
You're welcome. Any other? I think that's the last question. Is that right? Anything else?
Unless anyone else has got anything that they want to say or ask. If not, then we will wrap up. So thank you, this has been really helpful. We're very glad that we're able to offer these sessions.
Thank you all for joining. It's quite intimidating sometimes to join large group. And in this way, the digital life is probably a bit easier. The questions were very, very quite, or thought a lot about your conditions and have brought up the things. So steroid sick rules, I think, is my number one thing. Exercise next to it. So do as much exercise as you can. And I think is an easy, common thing where people have not enough thyroxine because people don't think about them as pituitary patients being different. So they think, oh, this is a thyroid, so lower the thyroxine. So that all has come up. And then, yes, I have a lovely, lovely weekend. Thank you all. Thank you, Lottie and Kim, for supporting this.
Yeah, that's okay. Thank you. Yeah, thank you so much, Professor Stephanie. We're very, very grateful. Questions very, very well. So yeah, it's really nice to have such an expert on. I do just have a few things to say as we end. To you for free, and I know that some of you have donated already when you bought the tickets, but we are relying on donations from supporters. So if you found this to do so, then it would be really amazing if you were able to donate. So Kim's just popped a donation link in the website, or you can donate by text. So you can text Living Well 0085, and that would donate £10. And text would cost £10 plus one standard rate message. So yeah, we are very grateful for that. But yeah, so thank you so much, everyone, for joining. Everyone's questions so amazingly. Thank you, everyone.
All right. Bye-bye now. Bye-bye.